Dr. Kemi Olugemo, Vice President of Global Clinical Development at Ultragenyx. Kemi will be providing an update on GTX 102, ASO program in Angelman syndrome. I've heard some recent exciting news via press release, and today we will get the opportunity to hear more about progress to date. Kemi?
Thank you, Ryan. Okay, so here are some forward-looking statements. Actually, before I begin, good morning, everyone, and happy Veterans Day. And for any veterans that are here today, or for anyone that has a veteran in their family, we are grateful for your sacrifice and your service, and thank you profusely. So I joined Ultragenyx a year ago, and even though I've been in the industry for over 20 years, and Ryan was embracing his age, so I'm going to do the same thing today. I really haven't worked for a company quite like Ultragenyx. So our mission, since the company was founded 13 years ago by Emil Kakkis, is to transform the lives of patients living with rare and ultra-rare diseases. And in 13 years, I can say that the company has really been prolific in terms of getting drugs into trials and getting improvements, and the numbers that you see here speak for themselves. So we have three main therapeutic areas. We have bone and endocrine, metabolic, and neuroscience. And Angelman syndrome, as you know, falls under neurology or neuroscience. So some disclaimers. I'm going to be talking about GTX 102 and giving an update on the program. And GTX 102 is an investigational drug. It is not approved by any regulatory authority. I'm going to be presenting open label data, and the data are very encouraging and positive, but they're open label, so you have to take that into consideration. We will eventually do a phase 3 pivotal trial, which will be controlled and blinded, and will provide definitive evidence of any efficacy as well as safety. So the current trial is in phase 2. So it's a phase 1/2 open label study looking at the safety, pharmacokinetics, and clinical activity. And we're looking at domains that are really critical to individuals and specifically pediatric patients living with Angelman syndrome. These include communication, sleep, behavior, gross and fine motor, and seizures. So here you'll see there are many exploratory endpoints, and the idea initially is to cast a wide net. So when you start a trial, especially in a disease that has no precedent and you have no previous endpoints to really guide you, you have to cast a wide net. And so we have various outcome measures that you've heard a little bit about over the past 2 days that have looked at activity in all these different domains from the perspective of the clinician, of the caregiver, as well as a clinical evaluator. And today I'll be talking about a select few of these outcome measures. So as I mentioned, this is a first in human, open label dose escalating study. GTX 102 is an intrathecally administered antisense oligonucleotide, or ASO. We have a loading period followed by a maintenance period. The loading doses are given 1 month apart, and then the maintenance is 3 months interval. One thing that is unique about our trial is that patients who are in the trial can remain on the drug until the program is discontinued or the drug is commercially available. So here are some key eligibility criteria. Importantly, we're only looking at patients with deletion right now. Our age population is between the age of 4 and 17 at screening. We require that patients have normal kidney and liver function, and if they need anesthesia for their lumbar puncture, that they're able to tolerate it. And the eligibility criteria are designed in such a way that we can detect a treatment effect and also make sure that patients are safe. So if a patient has a bleeding or platelet disorder or any other condition which would make it unsafe for them to participate, then they are excluded. So I'm going to be sharing some phase 2 data from a select group of patients who have the largest body of longitudinal data. So 15 patients who were enrolled outside of the US with data up to day 506. These patients have received maintenance doses up to 14 milligrams. I will also present some additional data from patients who were redosed. So original cohort 1 to 3 patients who had a pause for approximately 2 years and started drug treatment again, and I'll give a brief summary of those patients. So what are the domains that I'm going to be discussing? So you see them here on the slide. They're all from either the Bailey or the Angelman syndrome assessment of the ASA scale. For the Bailey, we have cognition, we have receptive communication, and we have gross motor. And for the ASA, we have sleep behavior and an overall score. Importantly, we have a natural history comparison for the Bailey assessments. And the data that we used as a comparator come from the Ladder database. You heard yesterday from Wen-Han Tan about the update from Ladder. This is a database that has been ongoing for over a decade, and we used patients who had deletion, who were between the age group of 4 to 17, and similar age group to the patients that enrolled in our trial. These patients were assessed under Bailey 3, and so we converted the Bailey 3 scores, and we used transformed GSV scores, and we converted them to Bailey 4 using a calculation provided by the manual. So the first figures I'm going to discuss are from the Bailey, and they're the cognition subdomain. So if you look on the right side, you'll see the figure from the natural history. So this includes patients who were who had 2 time points, so a baseline and post-baseline scores up to 2 years. On the horizontal or x-axis, you see time, and then on the y-axis, you see the Bailey 4 scores, Bailey 3 converted to Bailey 4, and you'll see a green dotted line, and the green dotted line represents a threshold of significance according to the manual. This threshold is statistically significant, and we don't have sufficient data right now to say categorically that it's clinically meaningful, but there is some early work that shows that those thresholds are similar. So you'll see immediately that the patients who are untreated they make very small gains between their baseline assessment, their first assessment at 1 year, and then their second assessment at day 730, which is a 2-year time point. But they never come close to that green dotted line, which is the threshold of significance. So then if you look over to the left figure, this is a figure of GTX 102 treated patients. And you'll immediately see that by the 1-year mark, patients in this Bailey 4 cognition domain assessment have exceeded that threshold, and then they continue to improve right up until day 506, and we've highlighted day 506 for you between GTX 102 and natural history so that they're easy to compare. And then we decided to look at EEG, and unfortunately I missed the talk by Mike Sidoroff, but I heard he gave a really nice talk yesterday. And there's a growing body of literature that shows that in Angelman syndrome, there are some characteristic findings on EEG, and one of those is delta slowing, which you've heard about, I'm sure. And so patients with Angelman syndrome, especially those who are younger, will have a lot of slowing. And you see that depicted in the cartoon in red on the right. And so we decided to look at EEG delta waves and compare those to some of our Bailey and ASA data to see if there was any correlation. So looking at the figure on the left, you can see GTX 102 treated patients. Again, on the x-axis or horizontal axis, you see time. And there are little purple arrows, and they show the time points at which GTX 102 was administered. And you see at day 128, right right around the time patients have received all their 4 loading doses, there is a reduction in the delta power. And then by the time you get to day 254, which is really the first time point which you can assess the effect of loading, you see a significant reduction in delta power. And so, we know from the literature that delta power reliably predicts cognition, and we looked specifically at the change in the Bayley-4 cognition GSV scores at the day 254 time point and compared those to the change in delta power reduction, and we did see a correlation, which was very encouraging. So moving on to receptive communication. So again, similar comparisons. Right side is natural history. Green dotted line is threshold of significance. You see gradual improvement in untreated patients in natural history, but they never exceed that threshold. And then on the left, you see GTX 102 treated patients and the receptive communication domain score on the Bayley, and they exceed that threshold, and through maintenance, they maintain the improvements that they have. And these are mean scores of all the patients that were assessed at that time point. Moving on to the gross motor assessment for the Bayley, again, with natural history on the right, you see very gradual improvement that never exceeds the threshold. And then on the left, you see improvement at day 506 that clearly is continuing to improve and exceeds the threshold of response according to the manual. So in terms of the Angelman severity assessment, this is essentially a CGI scale looking at disease severity, and it rates a patient's symptoms based on ratings of 1 to 7. So you can see them there. 1 means that they're not at all impaired, and 7 are among the most severely impaired. And for our cohort of patients, most patients at baseline were mildly to severely impaired. So importantly, a reduction of the score, so if the score gets lower, that implies less severity and implies improvement. So here we're looking at the sleep domain of the Angelman severity assessment, and on the left you can see over time that on average patients are improving in their ASA severity score in the sleep domain. It's important to note that this is not an improvement or change score. This is a disease severity score, so a change of about 1 point in a period as short as 254 days is really quite significant. And then on the right side, you see some EEG data that shows that patients had increased sleep spindle duration that coincided quite nicely with the improvement in their ASA sleep scores. Looking at the ASA behavior domain, we also saw that similar improvement or reduction in the score. On the table on the right side, you see some of the anchors that we saw that were having the greatest degree of improvement. So patients had easier time having transitions, they were less impulsive, less excitable, and exhibited fewer maladaptive behaviors. And then lastly, the ASA overall score, again, decreasing over time through maintenance and continuing to improve. So then we looked, moving on to patients who started treatment on the very earliest cohorts, had a pause due to a safety event, and then started again after 2 years on a lower dose. So here you see 3 patients who were redosed, and you see green cells that show skills that these patients gained, and they span all the different domains that we talked about: receptive, expressive communication, behavior, sleep, fine and gross motor. And every patient didn't have the same issues at baseline, but a number of skills were gained, such as being able to attend more to family and friends, recognizing family. People describe sort of the lights being turned on, being able to follow a 1-step command and then subsequently a 2-step command. Sleeping through the night was huge for patients as well as their families. as well as the acquisition of fine and gross motor skills. Unfortunately, these skills were lost when drug was interrupted for approximately 2-year period. For any patient that lost skills, all of those skills were regained after the drug was resumed at a lower dose. So we can't talk about efficacy without looking at safety, because benefit risk is really critical. And so here you see a summary of the safety data for all the patients in the trial, not just the patients with the greatest longitudinal data. And you can see that most of these adverse events that we're seeing are related to procedures, so the lumbar puncture procedure, such as vomiting, either the lumbar puncture itself or the anesthesia that was required to give the drug. Again, events like fever, infection are common in pediatric patients, especially in the age group that we're looking at in this trial. Importantly, we have not seen any unexpected adverse events or new safety concerns since the last update. This represents data, as I mentioned, for the entire cohort, and patients have received up to 11 consecutive doses of GTX-102. So in summary, for our interim phase 2 data, we see an improvement in the Bayley-4 receptive communication, cognition, and gross motor domains, both in the loading and maintenance phases. And we see a significant separation from natural history using the latter database comparison. We also see that the changes in the Bayley were associated with reduction in delta power on EEG, as well as increased sleep duration being correlated with the ASA assessment. And so this reinforces the potential of EEG as a biomarker for use in Angelman syndrome. Cohort 1 to 3 patients who lost skills, lost new developmental skills, were able to regain those skills after they resumed study drug at lower doses. So we've received a lot of questions about patients who are currently excluded from our current trials, and these include non-deletion patients. And the company has expressed the plans to actually look at those patients and to include them in future trials. And we just want to reiterate that that is still our plan. We are actively exploring specific doses and dose regimens that would be efficacious and safe in patients who have other genotypes. So, for example, patients with missense mutations who have some retained UBE3A protein function may require a different dose. Patients with UPD may require a lower dose. So we just don't know, and we have to make sure that we are taking the right precautions to ensure that any patients that we enroll are safe during the trial. Similarly, for patients who are younger than 4, we do plan to study these patients as well. The timing isn't exactly worked out yet, but we would like to do this as soon as possible. That's definitely the intent. We've also received questions about patients with prior ASO exposure, particularly other ASOs for Angelman syndrome, and we just don't have enough safety data right now to know about any potential long-term sequelae from previous doses, and our focus really is on phase 3 to ensure that every patient, living with Angelman syndrome can have access to our therapy. So, we haven't forgotten about this, group of patients, and we definitely encourage you to, families to talk with your treating physicians about any specific concerns you have. So what are our next steps? We'll complete enrollment of our expansion cohorts. We expect to have data in the first half of next year. We have phase 3 planning ongoing, and then we'll communicate timing of the other groups that I mentioned that are currently excluded from our current trial. So I really owe a lot of gratitude to our clinical team. Some of them are here today. This definitely is not a complete list of people on the team, but they are just incredible human beings, as well as drug developers who care about the patients and their families and care about doing great work and really have both scientific rigor and integrity, and I'm really fortunate to be working with such a wonderful team. I would be remiss if I did not thank FAST, thank all the families for all the time that it takes to participate in trials, participate in natural history studies, all the sites and investigators, and the entire community for all your tireless efforts. Thank you.
So we have time for 1 or 2 questions, max. We've got one right here. I'll get out of your way.
Hello, thank you so much for the talk. I was wondering, when you showed the comparison between patients that are on the drug and natural history patients, would it also be possible to just to gauge a sense of how important the improvement is, to compare the patients that are on GTX 102 to like healthy positive controls, so just regular random people, and what that looks like?
Yeah. So, patients with Angelman syndrome on the Bailey assessment, so the Bailey assessment, which is what we use for the natural history comparator, looks at developmental age up to age 42 months. And so that is because patients with Angelman syndrome don't really improve beyond that, that time point. That was felt to be really the most important comparator, to use rather than a neurotypical patient population. There's also a large body of literature on the Bailey. Bailey has been used in other clinical trials in neurodevelopmental disorders as well as in Angelman syndrome. So we felt that that was the most appropriate comparator to use. But that is a good question. Thank you.
Hi. I noticed over the 508 days that your study subjects dropped by about half. Can you talk about the ones that dropped out and how those, whether they might have dragged down the results for the others had they continued?
I'm sorry, can you repeat the question?
Yeah.
So the number of subjects enrolled in the study went from 15 down to about 7 or 8, I noticed. So why did those drop out, and how might they have affected the results?
So those don't reflect dropouts. Thank you for the question. So they reflect the data cutoff date that we used for the last review of interim data. So it means that that's the number of patients that had a day 506 time point, but all the other patients were still in the trial. Does that make sense? Thank you. Is that good?
Great. I
Okay.
think we had one online,
One
but
more here.
do you want to take the one online, and then we'll save the rest for the panel at the end?
Okay.
Because we have to move through. Go ahead, David.
Thank you so much. Question from online. And the question is, what mechanism would allow for the loss of skills when off drug? Because the thought is unlearning without UBE3A should be just as hard as learning without UBE3A. Maybe there might be some understanding, maybe some of the basic scientists in the room could have some ideas on how that could happen.
Yeah. So, that's a really interesting question. It's something that we've, thought about as well. I think the different skills that get lost take a different amount of time to get lost. So one of the first ones that people will typically voice is either behavioral improvement or sleep, which gets lost really quickly. And, is it a matter of the knockdown of the antisense transcript that eventually, wanes? Is it the protein half-life? Is it a combination of both? We're not really sure, but it's probably multifactorial. Remember that even with the drug, patients still need to get additional therapy to be able to learn, because these patients have been, kind of stuck at a lower developmental age for a long time, and so they're going to need additional physical, occupational, speech therapy, et cetera, to catch up. So I would say it's likely multifactorial. Sorry, I don't have a better answer, but it's likely not one reason.
Great. It's a good question. Okay.
Okay, thanks.
Thank
Ryan.
you.